to you without a doubt. Now the water is rising.
Hello everyone, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Foley & Lardner. Just a few housekeeping items to go over. We'd like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. Stay on after the webinar to whip up some spooky appetizers with Chef Jennifer Clare of Home Cooking New York. And with that, I'll throw it over to our moderator, who joins us from Foley & Lardner, Chris Donovan.
Thank you, Jody, and welcome to today's webinar. My name is Chris Donovan. I'm a partner at Foley & Lardner and co-chair of the healthcare industry team. And today's topic is highly topical, I guess you could say, no pun intended, the sort of the intersection of behavioral health and technology. And we've got a terrific panel with us today. And what we've tried to do with these webcasts is sort of discuss the topic from multiple angles, the payer, the provider, and the technology aspect of it. And I think we've got three terrific panelists to help us explore the topic. And I'll just introduce them briefly, and then they can introduce themselves for a minute or two. We have from Magellan, Sarah Ahmed, who's the Senior Vice President of Product Innovation. We have Rob Marsh, who is the COO of Kindred Behavioral Health on the provider side, and we have Dr. Justin Hunt, who is the Medical Director of Ginger, a behavioral health technology platform. So maybe I could just ask the three panelists, looking at my computer, just Dr. Hunt, you're sort of first to the right of me there, if you wouldn't mind introducing yourself and then handing it over to Sarah and Rob, and then we'll get into the meat of it.
Great, it's really wonderful to be here. Dr. Justin Hunt, I'm the medical director and head of psychiatry at Ginger, which is an on-demand mental health system with coaching, therapy, and psychiatry. Before I went into industry, I spent time in academia, both at the University of Michigan and the University of Arkansas for medical sciences, as well as in the VA system. Really excited to be here.
Thank you, Justin. Sarah, do you want to introduce yourself?
Hi, I'm Sarah Ahmed. I'm a Senior Vice President of Product Innovation and head of the Magellan Health Studio at Magellan Health. So I've been exploring and leading in healthcare for over 25 years now, and I think of myself as a bit of an operator turned innovator. I spent 22 years at Humana in big operational roles like product and network and clinical and everything in between, and then got exposure to this whole new world of innovation, working with startups in the Valley and learning about human-centered design. And also that role really opened my eyes to reimagining healthcare and a whole person approach to care across the physical and behavioral healthcare continuum. So I got to continue some of that over at Highmark Health, applying human-centered design, transforming the experience in the care delivery system. And now at Magellan Health, which is a leader in managing the fastest growing, most complex areas of health with core clinical excellence in behavioral health, I get to lead a team of folks in the Magellan Health Studio, and we are reinventing physical and behavioral health experience for the people we serve through new integrated solutions powered by transformational capabilities. And it's really the best place for me to be professionally and personally, as my family lives with severe mental illness every day. So my passion for dissolving the stigma is very real.
Thank you, Sarah. Rob, do you want to introduce yourself?
Yes, certainly. Hey, good afternoon, everyone. This is Rob Marsh. I am the Senior Vice President and Chief Operating Officer for Kindred Behavioral Health. I've been with Kindred for just over a year, brought on specifically to help grow the behavioral health line. You know, what we're doing at Kindred is building not only behavioral health hospitals and systems within communities, but we're really focusing on the ecosystem of behavioral health within the markets that we serve, looking at different ways that we can connect the community to the facilities that we run, as well as how we can contribute back to the community in terms of behavioral health innovation and making population health better, particularly as it relates to behavioral health. Before I joined Kindred, I worked for another large provider of behavioral health services as a division president and also as a hospital CEO. I'm really happy to be here.
Thank you, Rob. Thank you, Sarah, and thank you, Dr. Hunt. And just before we get into it, if anyone has questions, queue them up in the question toolbar on the bottom. We intend to kind of answer those to the extent we can during the next 50 minutes that we have together. So we look forward to that. Maybe just to kick off the conversation, I've got some notes here, and I was trying to conceptualize where behavioral health is right now, and its intersection with a lot of things, frankly. And I came up with kind of a shorthand for 3 C's: culture, COVID, and capital. And certainly, as we've been talking about it and seeing it, certainly behavioral health has turned the corner from something that was sort of a stigma to something that is, frankly, effectively the functional equivalent of a medical situation or physical medical care, backed off of, as supported by various parity laws, et cetera. And I speaking for myself, I have 2 20-year-olds, and they think nothing of getting therapy for some of their concerns. And my wife and I are totally supportive of it. So there's a whole cultural shift, I think, coming up from the younger generation, speaking for myself. And I think it is healthy and it's positive. Certainly the COVID crisis and the isolation and challenges some people are dealing with now, in addition to healthcare issues, has accelerated, I think, the topic, the access issue, the effectiveness, its coordination with primary care, like Sarah, you were mentioning. I think certainly that's been a feature of what's happening now. And with respect to capital, I'm just noticing in my own practice, in our law firm, that there is a very, very high interest in the form of the investment community, both private equity, venture capital, and strategics in entering this space. It's actually an area with enormous growth, pretty fragmented, and an area where I think a lot of investors and professional investors think they can actually provide more than capital in terms of providing value. On top of that, and I'm sure Sarah will talk about it a bit later, we're definitely noticing an increased interest in the payer community in understanding that behavioral health actually is a key component, not only to better health, but also to cost of care, overall cost of care, and that intervention in some cases in an early case may actually be beneficial in terms of producing better outcomes at lower costs, which is, as we all know, the holy grail. So anyway, with those comments, I just sort of an open question for the 3 of you. I like kind of sports metaphors occasionally, and I'm kind of feeling like we're in the early innings of this thing, but maybe not. Maybe we're in the back end of it, and I'd like to kind of get your sense of where we are with behavioral health. Maybe some comments about where we are with technology, because I know the 3 of you have various aspects of your business that dovetail into technology, some more directly than others. But Dr. Hunt, maybe I'm going to stick with my rotation here, and unless there's a question that obviously focuses on one of you, but I'll keep going sort of left to right on the screen. If you could kick it off, that'd be fantastic.
Yeah, absolutely. Well, I think while we've seen significant progress, and especially over the past year, in reducing stigma and then also increasing mental health healthcare access, I would say we're definitely still in the early innings. We are by no means to the 7th inning stretch, and I would say probably in the first 3 innings still. There's still a tremendous, and I would say even widening, supply and demand gap between those who are seeking care and those who provide it. Even pre-COVID, before we had this kind of latest increase in volume with respect to behavioral health, it was estimated that the gap for mental health providers was estimated to be about 250,000 by 2025. And I know it's particularly acute in my own discipline of psychiatry, where there's a real significant shortage. And of course, that plays out very differently in different geographies. And then also if folks are kind of in network versus out of network with the payers too. That said, I'm encouraged by the amazing amount of innovation in this space. not only in the Silicon Valley area, but truly across the country in many different locales like Raleigh, Durham, and multiple other spots. And I think we're also seeing some relaxing of the some of the regulatory barriers in this space too, particularly with telepsychiatry, where we're seeing some loosening and cross-state licensing post-COVID, and many of us are wondering how many of those regulations will stay kind of in the place that they are now versus kind of going back to the previous state. And then I think there's an amazing amount of collaboration that's happening between providers, between payers and providers, and other kind of key stakeholders in the mental health industry. So I think that's a early innings, but bright future.
Yeah,
Early innings, but your ace is on the mound and looks like he's going to continue into the mid stretch. Sarah, what? You don't have to continue with the baseball thing anyway. You can take whatever approach you want.
I'll stick with the innings. I will.
Okay.
Completely agree with Dr. Hunt. I always take it all the way back to pre-COVID and globally, and I think globally and then U.S. and there were almost 800 million people that had some type of behavioral health diagnosis in the world, almost 11% of people. And that's staggering. And when you think about the US, 1 in 5 adults experience mental illness every year. 1 in 25 adults experience serious mental illness every year. So that was pre-COVID. And then you take now where we are in the middle of COVID. And there was a survey done from the American Psychiatric Association in March that showed about 36% of Americans felt that the COVID pandemic is having a serious impact on their mental health. And so those numbers are only going to increase, especially when you think about the impact to healthcare workers, frontline workers, doctors, nurses, teachers, really all of us. So with regard to the treatment and access during COVID, to me, that's one of the things where we're kind of in the second inning. We have the access, we have the treatments, but with technology, it opens up a whole new world for us around access and getting people the care that they need through telemedicine and digital interventions. But I still think we're in the first inning with regards to engagement in that technology, because if you don't have that engagement, that sustained engagement, for instance, we're creating an engagement model at Magellan that identifies, targets, activates, and creates that sustained engagement over time for all of our solutions, because without that engagement, you don't have any outcomes. So you can build the best telehealth, the best digital solutions, but if you're not hooking them and getting them to use it and getting them to have that sustained engagement over time, you're never going to get to those outcomes that we want to achieve for people. And that's just better health overall.
Couldn't agree with you more. Rob?
Yeah, absolutely. Sticking with the baseball metaphor, I agree with Sarah and Dr. Hunt. I think that we're in the early innings when it comes to access and availability. If you look at the availability of, let's just say, inpatient psychiatric beds in America right now, we're some 90,000 beds short today. And that's just simply to meet the very minimum that we have in population today. So the problem's only going to get worse as the population grows and as a result of the increased need that we're going to see because of COVID. When it comes to understanding behavioral health and acceptance of behavioral health, I think we're further along. I think we're probably in the mid inning, somewhere along the sixth inning, if you will. As you said just earlier, Chris, that there's a new generation coming up that really understands the importance of mental health, understands the importance of therapy, and understands the importance of getting care and treatment further upstream prior to those critical points where they're not able to manage in the community anymore. I think that, to take it the metaphor one step further, I think we're still in the parking lot when it comes to the collaboration and cohesiveness of the behavioral health systems. It's not lost on me that if a person goes into a med-surg or short-term acute care hospital with some type of cardiac event, they've got cardiac care, cardiac rehab, home health, and an entire ecosystem that, again, supports them. The systems that we have within behavioral health are so disjointed. There's very little continuity between one level of care and another. And that's where patients really get lost. So I think that, hope's on the horizon. I think that we're having those discussions. I think that the next generation is going to have even more robust discussions. And I do think that they are going to be leading when it comes to technology and technological advances to push behavioral health forward.
One thing I'm connecting with all the comments here is the technology aspect of this, and the fact that I think, let's just say the younger generation has adopted technology more facilely than the older generation. And one thing that you said, Sarah, which is engagement. I'm wondering, one of the questions I guess I have in terms of areas where we think we can accelerate the growth of engagement, adherence, pull us into the later innings. Are there areas we talk about behavioral health, that's a very wide spectrum. It could be anything from substance abuse to autism to anxiety. Are there areas within that spectrum from your various perspectives, payer, provider, technology, platform, that you believe will be able to accelerate growth on a more on a greater level than others, and kind of considering one example I've seen, and I is substance abuse, for example. There's data out there about substance abuse not having, if you don't have the adherence associated with someone with an opiate disorder, for example, and they don't have regular mental health therapy and regular medical treatment or pharma treatment, the adherence and the recovery level tends to be significantly worse. So that strikes me as an area, for example, where technology could accelerate the penetration, if you will, of better care into behavioral health. But I don't know if you agree with me of that, or you don't, or maybe there are others. So maybe just again, we'll keep our rotation going. Dr. Hunt, what's your perspective on where maybe some of the growth areas that might be very appropriate for technology to kind of accelerate in behavioral health?
Yeah, at Ginger, we tend to be focused very much on kind of upstream issues. So kind of taking a preventative approach, which is kind of where our name came from too, kind of the preventative health aspects of Ginger. So, with our coaching, which is all done via chat, text-based chat, it's kind of in many ways, kind of a different on-ramp into the mental health system. So they're not scheduling that therapy visit or that psychiatry visit where they have to drive into the community mental health center parking lot, park in maybe some small town where everybody knows their car. They can access the text-based chat coaching right away. And gosh, almost 85 to 90% of the users of Ginger are doing coaching text chat only. And we are monitoring them very closely to see if we need to escalate up to therapy or psychiatry. So really kind of capturing via technology those issues that are maybe kind of small issues, but they could fester into bigger ones and actually develop into psychiatric disorders, but catching that on the early end. I would say the other thing that we're very passionate about is measurement-based care that I know we might talk about later as well, but really focusing on outcomes, building the technology where it's easy for members to engage with the app, fill out a validated scale like a PHQ-9 for depression or GAD-7 for anxiety, and then make it easy also for the clinicians to then track that score over time so they can truly kind of make treatment decisions based in some data.
Fantastic. Sarah, any perspective from the payer community?
Yeah, so I've got about 3 areas of growth opportunity. And one, you went with the substance use disorder. And coincidentally, Magellan just announced today a minority investment in Caden. Caden offers a virtual form of medication assisted treatment. It combines the virtual visits, the telemedicine type visits for medication maintenance, with virtual group therapy using the face-to-face video that's inherent in their platform. And that's between the patients and the providers. So it transforms that care experience, and it obviously increases access to care, but then increases retention and engagement. So our partnership with them, we're very excited about, because it also leads in to another growth area around collaborative care. And so when I say collaborative care, I mean the truest form of providing a licensed therapist that access and interaction to a PCP to help with that medication advice and guidance, as well as some guidance around the assessments that may be done by the PCP in the PCP's office with the patient. So you're providing that licensed clinical practitioner to the PCP, but also providing a care manager to the member, to the patient. So they interact through telemed, through that virtual two-way to get the support that that member or patient may need throughout their care. So it's both looking at the physical from the PCP and the behavioral from the therapist and the care manager. So having that telemedicine added into that interaction really helps with the engagement. And then finally, along with the collaborative care and the physical and the behavioral that goes into that is looking across that whole care experience. So making sure we are considering both the physical and the behavioral, all the way from well-being and emotional awareness and well-being to self-management using cognitive behavioral therapy, the care delivery and care management setting, and even in the home. So making sure that we are considering the whole care continuum, both physical and behavioral. I truly believe that's a big growth opportunity, and that really gets to transforming the experience, which therefore gets to getting people more engaged.
That makes sense. Rob, do you have any observations from the inpatient standpoint?
Yeah, absolutely. So, from a provider standpoint, I think that the real areas of opportunity and growth are really going to be focused around the utilization of technology to engage patients. It's interesting to me that there are no subsidies to support an EMR launch at any behavioral health facility. I mean, obviously, we know that the acute world receives subsidies in order to launch EMRs across the country. And it just goes to show you that there's a lot of work yet to be done when it comes to behavioral health and the application of technology. When the majority of providers are still using paper charts in order to track the care of treatment of patients throughout the care experience. I think another really strong growth area is how do we engage patients post-discharge and while they're in therapy and while they're leading their lives. I think one of the most exciting things we've seen recently is conversational AI and the ability to connect with patients in a meaningful way that allows the patient to understand, what are the goals that they established when they were in treatment? Are they following those goals? Are they meeting those goals? Are they following the steps that they need to be successful, such as medication adherence and visiting with their therapist and their physicians on a routine basis? The exciting part is that it provides interventions as necessary and let the patient drive the work streams back to the facility or back to the providers in order to prevent the rehospitalization of the patient or the relapse of a substance use disorder patient. And then the final thing I'll say in terms of a real growth opportunity, and again, it's really based in technology, is being able to look at the patient throughout the care continuum in a meaningful but very objective way. We're working with an organization right now that's going to provide us with what's essentially a care manager module. And in that module, we'll be able to track the patient's utilization of services, whether that's filling of scripts, whether that's seeing a physician or seeing a therapist, and we'll be able to monitor that patient. And when we see that the patient has not been able to, or hasn't refilled a necessary prescription, then our care management team can engage the patient and find out if there are resource issues or if there are problems accessing the medications. Again, that's going to give the patient a better chance for long-term, better mental health, and it's going to prevent the patient from relapsing or that rehospitalization.
I'm just listening to the three of you. I sense there's a potential business transaction we can put together. It's a very common theme of care coordination here, both on the technology side, the payer side, and the provider side. So that's interesting and encouraging. And probably I'm thinking that accurate is in many ways as well. We've been talking a lot about growth, et cetera, and it does seem like this is certainly an area that we're going to continue to see growth into the later innings. But I think it was, I don't know if it was you, Dr. Hunt, that talked about some of the regulatory barriers. And as lawyers, when we talk about, telemedicine platforms, et cetera, we have a big digital group at Foley that, follows, the corporate practice of medicine regulations and the Ryan-Haidt Act and the Support Act and all of the other COVID-related waivers that have come with respect to cross-licensing of physicians and, in-person telemedicine and, payment for telemedicine and parity laws. It's an area that has absolutely exploded in terms of regulations, which I guess is good for us lawyers. And it's encouraging because it's facilitated access and growth, but the question mark is, will that remain to be the case on a more permanent basis post-pandemic? But I'm wondering, not to get into the legal angles on this, because we could go down a rabbit hole that we'll never get out of. But in terms of what you see as obstacles to growth, let's just say, where do you see those? What do you see? What problems are out there that could be solved and provide greater access? So I know, for example, somebody mentioned network access, just access to clinicians, and whether they're inside or outside of network, and some of the adjustments I've seen payers make. What are some of the areas that you think are obstacles, and maybe some thoughts about how those can be overcome? Justin?
I'm sure. Certainly one of the first ones that comes to my mind, being a physician that now has 34 state medical licenses. I've had lots of experience.
You're the friendly PC.
Applying medical licenses across the country to develop our 50 state medical PCs. And it is just amazing how redundant that system is. And I know there are some exceptions that have been put in place, and I don't know if those changes will really stick, because state-based licensing is a long-standing tradition, but it certainly would be one that would be very helpful to improve access, kind of from a geographical standpoint. Another challenge is the Ryan-Haight Act. So we've been talking a little bit about substance use disorder. So with opiate use disorder, you actually think about medication-assisted treatment. That can get tricky too with the Ryan-Haight Act if you don't see that patient face-to-face initially, and then I think at least every 2 years per the Ryan-Haight Act. So actually at Ginger, we don't prescribe any controlled substances at all because of that limitation, because we're a pure virtual model and don't have any brick and mortar where we can do that face-to-face initial session. So that's a natural barrier. And then I think there are some kind of clinical severity barriers that you really have to work through as well, and in virtual care specifically. So, it still can be a definite challenge if you have someone with a severe primary psychotic disorder, particularly if there's lots of paranoia. It can be a challenge still to actually see that patient through virtual means. So that's something that we need to, I think about more from a technology standpoint, and how can we help resolve that so we can reach that population as well.
Yeah, I really think the virtual aspect and the state and federal regulations that have enabled an expansion to telemedicine and allowing more treatment for mental illness is just step number one. It's awesome. So glad that we are where we are, because it helps with those people who are worried, they're embarrassed or even ashamed of walking into a therapist office. And this gets to the stigma, right? I'm physically going to an office, and therefore I'm physically showing that I need that type of help. And if they're not comfortable with that, it may impede their progress in their treatment and where they want to go with recovery sometimes. So I think that being able to offer telemedicine and virtual solutions is so helpful for those people from a privacy standpoint. And that's great, to be able to deliver that. But that also means that technology has to be secure. We have to have secure platforms. We have to make sure that there's confidentiality and the data is protected, because there's data flowing through those sessions and recordings, and making sure that we are applying all of the compliance regulations that we need to against that technology. So although the world has opened up and you have access now to this technology, you have to make sure that technology is secured, and you have to make sure that that is intact. So there are no hiccups with regards to any of that data being released.
And I would say that some of the, from a provider side, some of the barriers or challenges that we have as it relates to, behavioral health, I think, primarily it's going to come down to funding. I think that even though there have been great strides made over the course of the last few years, there still seems to be a lag at the federal level when it comes to funding for behavioral health services. Again, I think it's interesting that if you've got Medicare or Part A, You can have any number of episodes for a cardiac issue or diabetic issue, as many days in the hospital as you needed. But if you have a behavioral health problem, Medicare is only going to pay for 190 days for your entire lifetime. And if you're a schizophrenic, or if you've got bipolar disorder, you've had to access those services from Medicare early on, you can imagine that by 25 or 30, you no longer have coverage from Medicare. So I think that's probably the biggest barrier as we see it on the provider side. It's just simply, how do we get funding streams that make sense for treating the population that we have. I also think that the use of technology, I think, is fantastic, because it really helps to start break down the stigma associated with mental health. People feel more comfortable being able to use technology in order to talk about mental health, the challenges that they're having. They're more open when it's a technological platform as opposed to an in-person platform, is what we've seen time and time again. But I think that the big problem isn't necessarily the technology or the availability of it. It's the stigma that's still associated with mental health. And the only way we're going to get rid of that, the only way we're going to address it, is just simply by talking about it as often as we can and normalizing the need for behavioral health, mental health. It's just as important as physical checkups, just as important as insulin or any other thing that somebody might need to lead a healthy life. And then just finally, one question came up, and it was really about how do we incorporate behavioral health and technology associated with it at the hospice or the home health level of care. I think that's a very good question. The technology is already there. Technology that will help a patient at home or on hospice do a self-evaluation on how they're feeling. Dr. Hunt just mentioned a minute ago the General Anxiety Disorder 7. It's a self-assessment tool that helps us understand if the patient has anxiety. There are other assessment tools that assess for post-traumatic stress syndrome or trauma, for other areas of behavioral health and substance use disorder. I think the technology, being able to utilize the technology, asking the patient to self-evaluate themselves, whether they're at home health or in hospice, and then the technology to provide them tools and resources to address some of the challenges they're having. For instance, if there is a note that the patient has high anxiety, the technology can play a video that shows the patient how to be mindful and how to lower their anxiety without the use of medication. So the technology is there. It's just really the adoption of the technology in its widespread use.
Makes sense. Adherence. One thing there was a question that came up too. You just answered one. Thank you, Rob. But there was another one in terms of access to clinicians, and particularly psychologists and psychiatrists. We've done a lot of transactional activity with investors who are investing in this space. And Dr. Hunt, you mentioned the corporate practice of medicine and rolling out these management service organization PC models across the country. And one of the things that strikes me about this is network access and just adequate access, if you're in a health plan, to clinicians in a geographic area. And I've heard anecdotally friends and colleagues who've a combination of not having access to clinicians and sort of the privacy issues of not wanting to go through their insurer and having to get approvals from their MD or their PCP and just paying for it privately, which I guess is a solution for some people. But in terms of expanding access through, typical commercial health coverage, I'm wondering what your observations are with respect to, recruiting clinicians, bringing clinicians into network. I guess that for all three of you, are there access issues with respect to, in network, out of network, just clinicians? I mean, some of that's solved by telemedicine, obviously, but it does seem anecdotally that I'm hearing that, and that might be an obstacle that needs to be focused on. And I don't know if there's an immediate answer to it. So since you're a doctor, Dr. Hunt, maybe I'll start with you with this.
Sure. One thing that we concentrate on when we're recruiting folks is we really want to make the clinicians' lives easier. So we really focus on building tools for the clinicians. So it's not only tools for the patients. Obviously, that's very important. That should be kind of our North Star, but you also have to keep the clinicians happy as well. So you're building an EMR that's easy to use, promotes measurement-based care, things of that nature are very important as well. As far as the in-network, I do see that some. So we recruit largely 1099 contract therapists and psychiatrists across the country. And a large number of the therapists and psychiatrists that work kind of part-time for us in a 1099 capacity are doing just kind of cash only practice in certain geographies. And it does play out differently in different geographies too. So there, sometimes in large metro areas like, the Bay Area or New York, there's a population that can pay for that cash only kind of psychiatric service where they could be paying up to $300 to $400 an hour for a psychiatric visit. But I mean, how many folks in the country in Arkansas where I'm based can truly afford that? So that's a very real access barrier when providers make that decision to not be part of a network and go cash only. You're going to select the population that can just afford that. So it's a very important thing to think about.
I'm on mute. I was told not to do that. To you, Sarah, in terms of network adequacy.
Well, I mean, I completely agree with Dr. Hunt. I mean, we all know that there is a access issue in the world, but I'd rather focus on the fact that even if we had all of the providers and all the clinicians that we needed, I still think we have a barrier to people being ready to access, to want to access because of the stigma, because of the just the readiness. So I'd love for us to focus more time on what we need to do as a society, as a world, to make it okay. And I think, Rob, you mentioned it earlier about talking about it and being okay to say, there's things going on with me, with my family, with my children, and having those open conversations. I was talking to somebody the other day. My child, one of my children, was diagnosed with ADHD. And it was incredibly confusing. And we were in denial for a really long time. Didn't know what to do, didn't know, where to turn with regards to the treatment or the therapies or even the medication, because we were also in a bit of denial whether or not medication was the right path for us. And so that was a moment where I realized we could do so much better with regards to helping people through times like that, because there's a lot of children these days being diagnosed, whether it's autism or ADHD. So I do believe that just having those conversations, opening up, those conversations with whether it's a neighbor, a friend, your doctor, anyone to provide that help is so important, because we got to make it easier for people to have those conversations, and it's okay to have those conversations. That's the world we want, right?
Sarah, I couldn't agree more. I think that you're right on target when it comes to having those conversations and being okay not to be okay, and being able to educate ourselves and the communities we serve and each other on the behavioral health issues and problems that are out there, and just learning more and being more prepared so that when we or family or friends encounter these moments in time, we're educated, we know, and we can identify it as a behavioral health, mental health, or substance use disorder problem, and not this negative behavior or something that I think is seen now. In terms of network adequacy, just to reiterate what my colleague said, it's across the country. There's a dire shortage of psychiatrists and practitioners that can treat behavioral health problems, issues, and diseases. I think that the solution, though, is to look at the care providers that we have now, and how can we modify some of the responsibilities that we have, some of the capabilities that the providers have, in order to give them more latitude in treating behavioral health. Nothing substitutes the care of a physician, of an MD or a DO, but there are opportunities where we can use advanced practice nurses and physician assistants in ways that they're just simply not being used now. Now, while I think we'd all feel much better if we had a behavioral health issue or crisis with one of our children, we'd like to see a psychiatrist, but gosh, if the psychiatrist isn't there, I'd like to also see a very skilled mental health psychiatric nurse practitioner. So I think that that's one of the ways, in addition to the use of technology, that we can break down that access issue and increase the overall availability of providers across the network.
That's an interesting observation, Rob, because going back to what Justin was talking about the loosening of regulations in behavioral health with respect to primarily telemedicine and the loosening of the Ryan-Haidt Act, there hasn't been as much on what I would refer to as the incident to reimbursement rules that allow NPs and non-physicians to basically provide the kind of care. So that's I like your idea of not. I mean, there's structural. I would assume problems with expanding, the roster of psychiatrists, MDs, DOs, but we can broaden it as we've done on the medical side. There was a question. Maybe I can just pivot a little bit over here to kind of on the payment side. There's been a lot of talk about value-based reimbursement. Really pre-pandemic, it's somewhat slowed down with the pandemic in terms of the emergencies, et cetera, but it's always been an area with behavioral health that I think makes sense in certain areas, but representing, for example, investors, strategic and private equity investors in a lot of transactions, for example, in autism. Somebody mentioned autism. They're all basically out there buying these companies, but in terms of coming up with an outcomes metric, for example, that shows that, for example, their treatment provides superior outcomes and that therefore should be, eligible for superior payment, or conversely say that they're willing to engage in a value-based reimbursement structure with a payer, for example, to get premiums or additional payments effectively associated with better outcomes. My own view of it is I can see certain areas like, for example, substance abuse. In a crude way, I can understand how adherence is going to accelerate recovery better with certain types of technology platform. Other areas, mainstream behavioral health, autism, I have a harder time, and I'm not an MD or a clinician, getting my arms around how to quantify that in a box. For example, similar in a way that you would go to a hospital and say, we'll pay you more money if your readmissions on hip replacements, are at X. That's a quantifiable, tangible, pretty regular, straightforward, and there've been federal programs with that have gotten into that. But I'm just kind of opening it up to see whether value-based reimbursement and the underlying outcomes measurements are something that we think is feasible now, or we're still more in a fee-for-service model. Justin, you want to kick it off?
Sure. Yeah, I mean, I think the crux of it is in order to demonstrate value, you need to have some good outcome measures, some good, valid, and reliable outcome measures. Where my brain goes on this, kind of going back to a model that Sarah mentioned earlier, kind of the collaborative care model, also known as the impact model from the University of Washington. I think about kind of value-based care oriented contracts that are kind of more whole health oriented. So, thinking about how if you deliver behavioral health with good access and with good quality, how you then can save dollars on the physical health side of things. It doesn't happen immediately. Often you kind of have to take a longitudinal perspective on this too. But I think the more these value-based care contracts can kind of have that whole person orientation, it makes more sense to me as a psychiatrist who loves to do kind of primary care, mental health integration. And I think there's so much kind of wonderful innovation in the Medicare Advantage space. And I'm thinking of kind of primary care providers like ChenMed and Oak Street Health, where it's kind of really kind of a fully capitated kind of model where they get a chunk of funds to care for their Medicare population. And I know that many of those organizations are very interested in integrating that behavioral health so they can reduce hospitalizations, both on the psychiatric side, but also on the medical side. Because if you take care of behavioral health, you're going to have better outcomes, with diabetes and other chronic medical illnesses as well.
So Justin, you went exactly where I wanted to go. So longitudinal view. And I look at everything now through this progression lens, right? And the outcomes should be based on kind of the progression and preventing some of that progression. So I think about it like with diabetes. So you mentioned diabetes. So, you can take a look at someone early and do the assessment to say someone is in the pre-diabetes space, and then monitor and measure over time how they progress. And some of the avoidance to some of those complications that occur, or the progression in the diagnosis with neuropathy and foot ulcers and amputations and retinopathy and blindness. So there's kind of this progression model that you can look at, and the cost associated. and then the clinical outcomes, and then how that person is affected, right? Now, this doesn't so much work with serious mental illness, but when you think about anxiety and depression, if we really get in front of that and do those earlier assessments and that identification, that would happen through the collaborative care model. So we would do the psychological evaluations, the assessments early, and identify where someone is in their behavioral health progression. Then you can start to monitor, where they go and how we help prevent any of those adverse events that could happen, or any of those complications, if you will, related to depression, like disability, or even worse, suicide. So I look at this through a progression model that we can only do if we get in front of it and have the assessment and identification early, and then monitor that progress through the care and the interventions that we are giving them over time in that longitudinal way.
I love that. I love the upfront to focus and trying to catch the issue before it becomes problematic for the patient and the communities that they're located in. I think the biggest challenge is how do we incentivize providers and payers in order to take those steps in order to prevent the individuals from becoming so depressed that they actively try to kill themselves or some other thing. I think the biggest problem though with value-based purchasing or value-based care right now is that as an industry, we can't seem to come up with what we think are the true measures that we need to go by. I mean, you take something like opioid use disorder. There are a number of different outcome measures that you might consider there, and which one is in fact the one that makes the most sense to put the dollars behind. To the patient, an outcome measure may be just simply abstinence. To a provider, it might be that they had no encounters with law enforcement, or they were able to control symptomology. So those are types of outcomes that we need to tie to value-based purchasing, but we just simply don't have a clear path there right now. There are some providers and payers out there that are thinking about it holistically. One payer that I know of is looking at incentivizing, but is actually incentivizing facilities and providers when certain metrics with their members are met, such as the overall behavioral health spend, the readmission rate, the compliance rate, or compliance with aftercare appointments and aftercare appointments rather. So I think that there's some movement there, but I feel like until we can further define how we want to measure those outcomes and what those outcomes should be, I think we're still a ways off.
I think this is really fascinating to me. I mean, one question I had for the three of you, just you were talking about the total care and collaborative care. I still feel like, if you look at the primary care industry, if you will, you mentioned a couple of firms, Medicare Advantage, Oak, et cetera, Justin, but I still think the overwhelming majority of PCP care is delivered on a fragmented basis. In other words, you don't walk into your PCP and then have 10 minutes with a social worker about your anxiety. And I don't know, and this is sort of a little bit off topic, but do you see, and maybe it's in part a solution to the value-based care, but do you see PCP practices that are either in network with you, Sarah, or in your experience, Justin, or Rob, that actually have under one hood effectively both a medical and a behavioral component, and are offering that as a whole solution? Do you see that as a trend line? I guess, and we had a related question in here about PD. I think that works well with the MA population to some extent, with seniors, but I'm not quite sure how it would work, for example, with a pediatric population. We had a couple of questions on the Q&A about behavioral health for pediatrics. So let me just, I don't know if that's a question or a comment, but I appreciate any follow-up from any of you or all of you on that.
Yeah, so we have seen in certain markets where there is this much more integrated care model that the providers and payers are utilizing. I'll use my experience in the Northern California market, where Kaiser has a very large presence. They truly do in their model there look at the holistic patient. They're talking about behavioral health at the same time that they're talking about the medical health and medical wellness of the patient. And I think that those types of models will prove beneficial and really the standard going forward. It really the challenge is that because they are both a provider and a payer, they're able to, influence the conversation quite nicely. Whereas, many times the payers are on one side of the table and the providers are on the other side of the table. So the more we can bring them together and start to integrate at that primary care level, just the better it's going to be overall. Now, as it relates to pediatric care, it's interesting from a provider standpoint of view. Pediatric care, of course, is probably the highest risk population that we serve, and there aren't very many, psychiatrists and nurse practitioners that feel comfortable treating children as young as 4. And when we do, we have to be very cognizant, of course, of all of the different family dynamics that are going on with that child, with that patient, and all the things that we've got to be thinking about post-discharge and, the aftercare plan and the accessibility of certain medications and things like that. It is a very special and unique population. I will say that the total number of pediatric beds in the US is woefully low because I think most providers, and to a large extent, I think payers are shy of taking on that high risk population.
But Rob, I'd say that identifying early, again, I'll keep going back to this, especially in a child population. I think the number of children that are being diagnosed with a mental health disorder, especially between the ages of 6 to 17, is incredibly high. It's like 1 in 6 in the US, and about 50% of all the lifetime mental illness begins around age 14. So I think 75% by age 24. So we have an obligation to get in front of this earlier with children, because when you do that, it's obviously going to lead to, again, I said, the getting in front of the progression and avoiding some of those adverse events. But back to the question around the integration, there's a lot of models out there now that are bringing together the behavioral health and the PCP. One example is Bayless in Arizona. They do a great job of executing on this model. And by doing that, then you can bring in that earlier stage assessment and screening, like I mentioned earlier, to identify those folks that have both the physical chronic condition and behavioral health conditions, so that you can bring together a care plan and management plan for both. So that type of model, I think, is increasing, but that's one example that's out there today that's doing a pretty good job at it.
Yeah, absolutely. I think it's just wildly variable across the country, and often it can be quite payer driven too. I mean, I know there have been some kind of innovative models in Washington State as well as Minnesota, really kind of helping to promote the collaborative care model. Fortunately, CMS has actually pushed out codes related to the collaborative care model. So there's been some good traction there, but I would say we're not quite there yet. I think it's a wonderful model in many ways, because when you think about telebehavioral health, that can eliminate the geographic challenges and geographic barriers we have, but we really need to think about the overarching model and how can we kind of spread expertise across a population, and the evidence-based collaborative care model is a great way to do that. At Ginger, we're actually partnering with a company called Accolade to do this very thing too, kind of in the virtual world, where we'll can work with Accolade. They'll help to coordinate care on the primary care side, do joint case rounds where we'll discuss behavioral health and primary care conditions together. And so that's kind of a virtual version of collaborative care.
That's kind of consistent with what, I mean, in some ways it's consistent with, I think, what I'm seeing really across the whole healthcare spectrum, what you're all saying. What I'd like to, I mean, maybe you can pivot a little bit, because we're getting a little bit late in the program here, and maybe looking into the future. I'm not to go back to the baseball metaphor, but kind of looking down the road a little bit. When we will come out of the pandemic, I'm kind of curious what your thoughts are, the three of you, as to where we are with behavioral health. Will we have more fulsome collaborative care at the provider level? Will payers actually be much more aggressively pushing value-based care models? Some of the things we've talked about with respect to unique populations, being the elderly or pediatrics. If you were to sort of put a dart out on the wall in a couple of years, 3 years, where do you think we'll be at that point? are we being in this, is it just further continuation at an incremental growth stage in terms of some of the issues we've discussed now? Or do you think there's some significant groundbreaking changes that will occur that will really reformat the whole nature of delivery of behavioral health? How's that for a loaded question?
I'll jump in here.
All right.
I'm going to go way far out there on this one. Okay.
Okay.
It's crazy. So,
Please.
Let's talk virtual reality. Okay. So I think people used to think that damaged our brains. And now there's some studies that say that it might actually benefit our gray matter a little bit. So when I think way far out there, there are some use cases that show that virtual reality can help us with diagnosis and treatment of behavioral health. Especially like in exposure therapy. So I don't know if anybody watches The Amazing Race. It's one of my favorite shows, but I think that is like the perfect use case for exposure therapy. Like you're in there, you're jumping off bridges and eating bugs and doing all this crazy stuff, and you're facing your fears. Well, virtual reality allows you to do that in a way that's much cheaper, much safer, and more, it's in a controlled environment. So when I think about that type of treatment for, fears and anxiety, how can we look towards virtual reality to help us in that way? That to me in 5 years will be something commonplace. But I really think we've got to think as innovatively as possible for some behavioral health conditions that can benefit from that type of, I would say, further out there technology, but it's gonna come one day for sure.
Yeah, I would think that within the next, say 2 to 5 years, that we're probably going to see just more of the same. Until I think the incentives are aligned across the board, it's going to be difficult to get all the players, to the same table, rowing towards the same goal. I do believe that, more and more will be looking towards whole person care, and there will be coalitions that are formed that help provide better care in neighborhoods and communities. But, until again, we're all thinking the same and incentivize the same, it's really hard to think about how you can pull certain providers or certain payers to the table in order to really benefit the overall community. I do think too, like Sarah said, that technology is going to continue in its utilization in behavioral health. What we're seeing today is just the scratching of the surface of its application throughout our industry. And I think that it's really going to start changing the way that we consider patient engagement in a meaningful way here, as it already has been, but even more so going in the near term.
I think kind of looking ahead to the next 5 years, I think there's going to be quite a bit of consolidation in the market as well, with kind of M&A kind of activity, particularly kind of in this kind of behavioral health innovation world that I live in. So many companies out there, so I think it's kind of ripe for that kind of activity. I think it's really exciting to think about. I love the virtual reality idea. I think we certainly should not put our neuroscience colleagues to the side either. I think science moves so quickly nowadays, and there's amazing work being done in pharma, and so we could see some much better treatments for many of our illnesses too, and that changes everything.
No, good point. One comment and one, if anybody wants to follow up on this, because we're getting late here, but I noticed all three of your companies. I know Kindred is in part owned by Humana, and Sarah, you just announced a transaction involving the acquisition or investment in a provider, and I think Dr. Hunt, you had mentioned you have collaboration agreements with some Medicare Advantage plans, but the sort of the one thing we're seeing actually when you say consolidation and M&A, we are seeing a lot of crossover between what I think, Rob, you were talking about the traditional construct of payer provider and sort of investments by health plans in providers and vice versa. So I mean, my own view is I see more of that coming, and that might be the thing that actually does accelerate the kind of care coordination in a very tangible way, as opposed to, for example, just pure government payments. Not that those incentives are important, but I'm wondering if the three of you see that, and maybe just if you can briefly comment, because we have 2 minutes left, whether you see that happening or not.
Yes.
That's brief.
That's wonderful to hear from Sarah. Yeah, absolutely. And I think that's how we truly move this forward, when you really kind of get folks on the same page. You know, spending some time in the VA, which is really kind of a payer provider kind of arrangement, you really in that setting, even though the VA sometimes is not famous for innovation, they actually were innovators in a lot of ways when it came to primary care behavioral health integration. It's been going on since the early 90s, telebehavioral health since probably the early to mid 90s. So it was easier to do in that setting in many ways. So I think the more we work together, the more progress we're going to see, definitely.
Yeah, absolutely. I think that that type of consolidation is just a way for the future. I do think that when providers and payers understand the pain points of each other and are working together towards alleviating those, you're only going to get better outcomes and more progress as we go forward. So definitely a trend that's going to continue.
Sounds good. Well, listen, I want to thank the three of you, Dr. Hunt, Sarah, and Rob, for joining me. And this has been a really interesting conversation for me. And I think it's just a really fascinating area, both, legally and just culturally, what's going on in the United States right now with this topic. And I think everybody can kind of take this to heart in terms of a personal aspect too. It's not something that, people are untouched by. I know, my own family, we have been touched by it. So I want to just thank the three of you. This was terrific. It is now 2:00, and I believe I hand it back over to Jody. And for those of you who are interested in cooking, invite you to participate in the cooking lesson that's going to be after us, after our home cooking here on this conversation show. Thank you, everybody. And Jody, I'll kick it back to you, and have a good day, everyone.
Thank you, Chris, and all of our panelists. If you'd like to continue the conversation, please join us on Twitter. And now, please welcome Chef Jennifer Clare.
Hello, everybody. I have a second camera. I'm not sure if you're going to allow me to turn that on, start my video. There we go. So welcome, everyone. This is not quite a cooking class, but it's all about food. So if you have some sort of food curiosity, I invite you to stick around and learn a little bit. So obviously Halloween is coming up, and so that's what's on everybody's mind. So we're always trying to do sort of thematic things. So we are making Halloween deviled eggs. But that may not seem like you're going to learn very much, but I do want to take time to introduce you to lots of different ingredients that you may not be familiar with, and also how to make a perfect hard-boiled egg. This is something that is typically a little befuddling for people. If you've ever tried to boil an egg and then peel it, and then you end up taking off half of the white and sort of cursing a lot and then never making boiled eggs again, I want to just show you a little bit more about how to get over that so you don't ever have to make a terrible boiled egg again. And also the different kinds of different hard-boiled eggs you can make, because even though there used to be one way of boiling an egg where you boil the egg all the way through, now there are different grades of eggs. Like the way that people like steak, sometimes you like your steak medium rare, some people like it well done. Well, eggs have a similar sort of a choice. So when you go, to a diner and you order your eggs, they say, how do you like them? So some people like them over easy. They like them hard cooked. They like them really firm. They like them runny. Well, the same can be true for a hard-boiled egg. So I wanted to show you how you make those different kinds of eggs. And I actually have a couple little demonstrations here of a good egg and a bad egg. So these are two different hard-boiled eggs, and they were cooked for different times in boiling water. So the best method, honestly, for boiling eggs is taking a small saucepan. Whoop, I took it away. But it's just take a small saucepan and put 1 inch of water in it, bring it to a boil, and then put in as many eggs as you can fit in a single layer. So the water must be boiling, 1 inch of water boiling, put in as many eggs as you can very carefully so they don't crack, and then put a lid on it. And you set your timer. You don't even adjust the heat. Let it boil the whole time. That's basically steaming an egg. It's not a great idea to boil an egg. It gets very, very tough if you submerge it in boiling water. So just a little bit of steam is going to be enough. So I wanted to show you, depending on the amount of time that you set on your timer, you're going to get a different result in your eggs. So these eggs down here, these are the 11-minute eggs. These are my preferred sort of time zone for an egg. You can see how beautiful the yolk is. It's bright yellow, and it has a little bit of a sort of a jammy center. So that term, jammy, has to do everything with how you like the consistency of your eggs. So if you've ever had ramen, if you've gone to a Japanese restaurant and had ramen, you'll see that the eggs that they usually put into ramen, the yolk is set, but it's almost liquidy, like jam. So a real jammy egg would only be about 8 or 9 minutes. That would have a really, it would be a firm yolk. It wouldn't be runny, but it would have those a really moist texture. These up here are what I called overcooked eggs. So these have been cooked for, let's say, 15 minutes. And I'll tell you the truth of the matter is, I actually cooked these for this demonstration this morning, but I set a timer for 11 minutes and I wandered away. And of course, when you wander out of the kitchen, you completely forget about them. So the timer went off and my husband turned them off, but he didn't take them out of the pot in the water. So it sat there in the very hot water for another 10 minutes before I noticed. So they are completely overcooked. So an overcooked egg gets sort of very dry in the center, and that's not very fun to eat because it's sort of, when you bite into it, it's going to, all of the yolk is going to sort of shred and fall apart. Another thing that happens when you overcook an egg is that you get a green halo around the yolk. So if you've ever gone, and had a hard-boiled egg and it has like a green ring around the yolk, that is an overcooked egg. And to my eye, when I see that, I don't want to eat that egg because I know that it's all dried out and it's not as good as it can be. So don't overcook your eggs. If you like your yolk completely set, like this little jammy thing kind of freaks you out, all you need to do is cook it for 13 minutes. 13 minutes in that method I talked about steaming it in a shallow amount of water is what will give you a perfectly hard cooked egg. So again, you can play around in your own home kitchen depending on how you like your egg. But again, that's the 11-minute egg. This is the overcooked egg. So somewhere in between those two, you're going to find the ones that you like. So that's just a little bit about eggs. Obviously, when you're buying eggs, you want to buy the best eggs that you can buy. When you go to the supermarket, honestly, the best way to choose an egg, you want to read the outside of the cartons. You want organic, you want pasture raised, you don't want any antibiotics in your eggs, the same that you would source good meat. But the difference in cost between like 1 dozen egg and the least expensive dozen egg in the supermarket and the most expensive dozens of eggs is usually about $3 or $4. And the rule of thumb is buy the most expensive eggs, because there's 12 eggs in there. That took a lot of time from a chicken to do. So it is very inexpensive per egg, but you should not be spending $1.99 on eggs because those eggs are very, very poor quality. Whereas the more expensive ones, the ones that have more pedigree, they're organic, the feed that they're served, the chickens are served, don't have any antibiotics or hormones. It's all vegetarian feed. Those are really important distinctions, and that will give you the best quality of egg. The best quality of egg comes from a chicken in your backyard, but not everybody has that. But a farmer's market is your second best, and a supermarket, the most expensive egg carton in there. And don't be afraid to spend $5 a dozen of eggs. That's how much they should cost. They shouldn't be that cheap. Anyways, I want to show you how to just flavor a couple of the eggs just to make something festive for Halloween. Obviously, Halloween is all about black and orange. So we are going to make 2 different fillings. One's black, one's orange. So I did empty out a couple of eggs into you take your egg, and once it's cooked and cooled, you just dump the yolk out into another bowl. Usually they pop out in whole. This one did not pop out quite so well. There we go. And then I'm going to use my jammy egg here, jammier egg. They're a little bit easier to season the filling because they are moist. They have more moisture still in them. So you're going to take all your egg yolks, and you need something to bind them together. You see, when you break up egg yolks, they're really powdery and dry. So obviously, the best thing to put into a deviled egg is mayonnaise, and I'm a huge fan of Hellmann's mayonnaise. I am not paid to say that, but it's a very good, very creamy, well-balanced mayonnaise. I do like my mayonnaise with a little bit of sweetness to it, and Hellmann's has that, or Duke's mayonnaise, any kind of your favorite mayonnaise. You could even do Miracle Whip, but you need enough mayonnaise in here to make a really smooth, creamy paste. Because when you bite into a deviled egg, if it's not creamy, then it's going to crumble and fall apart. Plus, it's not very good. So when you're seasoning eggs, you're going to always want to add 3 different ingredients to make it taste its best, and that's salt, fat, and acid. Those are the seasoning tools for most food. If you're eating food and it doesn't taste very good, you want to add salt or fat or acid or all 3 of them to get the best flavor. Now, mayonnaise happens to have all 3 of those ingredients. It has salt in it, it has fat in the form of oil, and it has acid in the form of lemon juice or sometimes a little bit of vinegar. All right, so I've got a nice little creamy puree here. So I'm going to divide this in half, and I'm going to make one filling that's black and one filling that's orange. But I want to introduce you to the ingredients that are going to do that for us, because I think that possibly you don't, maybe you don't have a lot of experience with these particular ingredients. All right, so the first ingredient I'm going to add is black garlic. So black garlic is basically fermented garlic. They take a whole head of garlic. So this is what a head of black garlic looks like. It's just a whole head of garlic that they put into some sort of heated area, whether it's an Instapot or a crock pot or an oven. And it is cooked and dehydrated over the course of a couple of weeks. So it's not really caramelized garlic. It's more like fermented garlic. It is jet black, and it no longer has any of that bitter heat that garlic has typically. It is now super sweet. So the best description of what I can tell you black garlic tastes like when you bite into it is balsamic vinegar or like tamarind. It's sort of a sweet, tangy, vinegary, fabulous ingredient. It gives an amazing tang to it. So like this is the whole clove. This is the whole head. These are the individual cloves, and inside each one of these cloves, you're going to find this jet black garlic clove. So I'm going to take half of this mixture, and I'm going to make black garlic deviled eggs. And I discovered this because someone gifted me some black garlic, which is not terribly easy to find, but if you shop at a place like Whole Foods, you'll find it. It's more like high-end grocery store. You're not going to find it sort of in your regular, let's say, like ShopRite or Key Food. It's a bit of a, I would say, I hate the word gourmet, but that's sort of what it is. You're only going to find it in a place that stocks slightly more obscure ingredients, because it has not hit the world by storm quite yet. Anyways, you're just going to mix this together until you have a terribly black, well, it's not so black as it is gray, but it's very good for Halloween. And you're just going to take a spoon, and we're going to dump it into, well, first of all, I'm going to taste it. I want to make sure it has enough salt in it. It typically is going to have enough salt because I added all of that mayonnaise, and the mayonnaise is already pre-salted. All right, so you're going to fill up your eggs with a little bit of this mixture. And then I was going to show you how to do a cute little decoration. I mean, you're in the middle of a very important work seminar, but this is your 15 minutes of nothing very serious. So we're going to make some spider eggs. All right, so I've got my 2 black garlic eggs, and I'm just going to take an olive, 1 olive per egg, and you're going to take a black olive, and you are going to just slice it into rings. Boop. I already have some, of course, set up for you. And you're going to put the little body there, and then you're going to make some legs by cutting the rings in half and just putting them on the side there. I don't know what people are doing about trick-or-treating right this year. So this would be a fun thing to do with kids. Of course, they want candy, but it is good to make sure that they have some sustenance before they imbibe a crazy amount of candy. Anyways, there's our little scary, spooky black spider with a black garlic filling. And I know it's kind of cutesy, but it's also crazy delicious. So the black garlic and the mayonnaise and the egg and the salty black olive, it may look cute, but it's also fantastically delicious. So it's definitely an adult treat. So don't be shied away, from the cutesiness of it. It's also very good. All right, next up, we're going to do our orange ones. So we're going to do we're going to pretend it's a little pumpkin. So we're going to take our same, get another fork here. We're going to take the same filling, which is just the yolks with a little bit of mayonnaise. And now we're going to try to make it orange. So we're going to use some smoked paprika, some turmeric powder, which is orange, and a little bit of sriracha for heat. Okay, so I'm just going to use a spoon to add these in. We're going to start with a healthy amount of smoked paprika. Smoked paprika is one of my favorite spices. It gives a wonderful smoky flavor. And it doesn't have any heat. So you can add cayenne pepper to this to make it hot, or we're going to add some sriracha also to make it hot. But the red is for turning this into orange, because as we all know from elementary school, yellow yolks plus red powder equals orange. So now we have a nice orange paste. But not only is it orange, it also tastes really good. It's smoky. And it would be really good with these other eggs as well. But I also wanted to see if I can get a little bit more color in here. So I'm going to use a little turmeric. Turmeric is this bright yellow powder. It also has a really nice kind of, I say bitterness because it has a bitterness to it, but that's not a bad thing. Bitter is often construed as a bad flavor, but it's really not. All right, so we're going to mix that in there. And then just to give it a little bit of, heat, you can use hot sauce, you can use Tabasco. I'm going to use a little sriracha because it's red and also just has a nice tang to it. It's vinegary, but it also has a little bit of heat. All right, so we've got ourselves some pumpkin colored filling. So we're going to get ourselves an egg and we're going to fill it up, mound it as good as you can. Now I could make this prettier by like putting it in a piping bag and piping it in here so it looks, very attractive, but chances are no one is going to do that at home. So why even bother showing you that? I don't want you to feel like you can't do this at home just because you don't have a piping bag. These are rustic. They're going to taste so good. All right, we've got our two little pumpkins there. And then if you really want to make it look like a pumpkin, you can put those little lines in it. Boop, boop, boop. And then I got myself a little chive here. So I'm going to stick a chive in the top there, and you've got like yourself a little pumpkin one. And I'm going to make it a little bit more pumpkin looking by tucking the filling in. And again, giving it those little pumpkin stripes that you can do. And that's just a chive. So you could do you can do like a scallion green. You can do like a little rosemary needle sticking out, because all of those things are edible. And as long as it's edible, that is all that matters. All right, so we've got little pumpkin ones. And we've got little spider ones. All right, there was your culinary break. I hope you enjoy it. I'm from Home Cooking New York. We're a cooking school in New York City. Obviously, currently we are closed since March, but we've gone online and all 6 of our instructors are teaching from their own home kitchens. I'm in the Hudson Valley of New York. And if you want to join us, we have about 5 or 6 different public cooking classes a week, from knife skills to boot camps from adults. We have weekly supper clubs for kids. If you've got kids and you want them to cook you dinner once a week, have them join our supper club. We'll walk them through it, and then at the end, you get to eat your meal. Or join us for anything coming up this holiday season. Thanksgiving sides, how to make a great bouillabaisse. Anyways, enjoy the rest of your conference. Thank you very much for sticking with me, and thank you for inviting me. Take care.
Thank you everyone for joining us. Have a great rest of your day.